Good morning, respected chairpersons, my teachers and my friends. First of all, I thank Ramesh sir, Deepthi madam and the entire organizing team of PeSuCON 2018 for giving me this opportunity to speak here. So, research has paved the way for newer inventions and discoveries. So, this has led to the better understanding of the pathogenesis and also the better evolution of better treatment protocols for various diseases. So, today I will be focusing upon the recent changes that has happened in the treatment of necrotizing enterocolitis. So, as we all know, necrotizing enterocolitis refers to an acquired inflammatory disease involving the gastrointestinal tract of the newborn infants. So, I would be focusing my talks on these broad four headings. The first would be the definition and staging of NEC, the pathogenesis of the disease, the newer biomarkers which has been developed in the detection of this disease, and also the preventive strategies regarding the same. So, as we all know, it was in 1978 when Dr. Bell first proposed the staging classification of necrotizing enterocolitis. This was one of the landmark papers at that point of time which helped categorization of the disease and knowing the severity of the disease. So, after this it has been modified only once, where the individual groups have been subclassified into 1A, 1B, 2A, 2B, 3A and 3B, but in spite of this it has so many shortcomings. So, it is not a staging criteria, though it is a staging criteria, it is not a definite diagnostic criteria. Why? Because early NEC, like what we call, that is in stage 1 disease, is not exactly categorized, is not properly defined in this, the Bell's staging. So, it does not differentiate NEC from other pathologies like either septic ileus or feeding intolerance. So, there is no proper categorization as to how do we detect NEC or whether it is a septic ileus or whether it is a feeding intolerance. So, the concept of new NEC which has developed nowadays. So, now we are, the NEC is broadly categorized into two broad categories, that is, one is the term infants having NEC and the other is the preterm infants having NEC. So, as we all know, the term infants is they develop the what we call as the So, the term NEC, infants usually develop the NEC at around 1 to 2 weeks of life, and the etiology specifically, usually they have associated IUGR or congenital cardiomyopathy. So, the whole, the endpoint being some kind of hypoxia related ischemia of the gut. So, it is basically ischemia related, the term NEC. Whereas, the preterm NEC, so there are various four subclassifications within that. What we now classify as the classical NEC, the transfusion associated NEC, the cow's milk or allergy associated NEC, and the contagion or lymphocytosis associated NEC. So, here the classic NEC, what we see in the classical premature or extremely low birth weight children, usually they develop around 3 to 4 weeks following birth, and the etiology being prematurity, preeclampsia, that's all well known factors with that, and again the endpoint being coagulative necrosis involving the intestine. So, usually the terminal ileum is involved. Whereas in the contagion associated NEC, usually we see this in the form of epidemics, where viral epidemics, we see these NEC patients coming in clusters. So, again the endpoint being ischemia and hemorrhage within the intestine and leading to necrosis. So, cow's milk or usually the breast, when these extremely low birth weight children are not given breast milk and they are giving some kind of formula milk, especially with the cow's milk, they develop this kind of enterocolitis like picture. Usually it is seen in around more than 6 weeks of life, and again it is classical allergy related eosinophilic phagocytosis and other things. And this is one of the new terms, that is NEC related with RBC transfusion. Here extremely low birth weight children having some anemia and severe anemia. So, these children, when they are exposed to at least one episode of transfusion, they develop this abnormal response of mesenteric blood flow velocity and secondary coagulative necrosis of the intestine. So, again this is one of the new concepts which has come up in the classification of NEC. So, how do we classify then? What is the new definition then? So, it was in 2017 when the international experts met and they formed a symposium, so where it was meant for the proper definition and staging of the NEC. So, it was there Dr. Gorton proposed this idea of the 2 out of 3 rule. This is especially applicable for preterm NEC infants, where patients may be given a diagnosis of preterm NEC if they have abdominal distension, ileus, under bloody stools and met at least 2 of the criteria. That is, the nematosis on the portal layer, which is detected either on ultrasound or on X-ray, the persistent platelet consumption, and if the age of the onset is less than around 36 weeks. So, who were excluded? So, infants known to have spontaneous intestinal perforation, infants with complex congenital anomalies, infants being fed less than 80 ml per day, and of course infants more than 36 weeks of gestation. All these were excluded from the study. So now coming to the pathogenesis of NEC. So as we all know, there are a host of factors which contributed to the premature related NEC events. So the newer things, which I am just going to highlight the newer things in these aspects. So here the important thing is regarding the toll-like receptor which is expressed on the apical surface of the enterocytes. We call this as the cross-switching hypothesis. So what are these toll-like receptors? These are normal receptors that are expressed on the surface of the gastrointestinal tract of the premature infants. So when these receptors are activated, either because of the bacterial colonization, the lipopolysaccharides involved in the bacteria, they stimulate these receptors, and once these receptors are stimulated, it leads to a cascading of events which finally result in the necrosis of the intestine. So I am stressing this aspect because all these have some kind of therapeutic potentials which I will be discussing later. So second thing is the decreased intestinal expression of transforming growth factor beta 2. Again, transforming growth factor is one of the important molecules which is involved in the development of the normal gastrointestinal tract. And it is, as the age advances in the maturity of the newborns, the concentration goes on increasing. So that means premature infants have lesser TGF-beta, whereas the term infants have normal levels of TGF-beta. This again has some kind of therapeutic and diagnostic benefit. I will come into that later. Then third level is the platelet activating factor. This is also one of the increased production, decreased degradation, and this is again a receptor which finally again contributes to the activation of the toll-like receptors. So this is one slide which tells us the most important thing is here we see the important aspect of the platelet activating factor. They cause activation of the toll-like receptors and finally leads to a cascading of events, finally resulting in the intestinal injury and apoptosis. So now coming on to the biomarkers, the newer biomarkers which in the diagnosis of NEC. So we have some 3 or 4 important newer biomarkers apart from the older things. So I have listed them in the recent to older order. So first thing is the intestinal fatty acid binding protein, the calprotectin, the serum amyloid A, the platelet activating factors, and of course older methods, that is the CRP, platelet count, cytokines, and the blood monocyte count. I will be discussing each of these in a little bit of detail. So intestinal fatty acid binding protein is a protein which is specific to the intestinal epithelium. So since it is very specific to the intestine, so it can be detected either in the blood or urine to detect intestinal epithelial cell death. So that means it is one of the important marker which is specific for the diagnosis of NEC. So and the further refinements, intestinal fatty acid binding proteins to creatinine ratio in the urine. So levels more than 70 indicate the severity of the intestinal damage. So it not only as a diagnostic marker but also as a severity marker. So of course it has its own shortcomings, that's okay. So calprotectin, it's one of the calcium binding protein found in the neutrophils and macrophages. So it is measured in the feces to detect neutrophil infiltration of the intestine. Again, the higher levels indicate the more severity of the disease. So again, it is one of the severity markers. That is, the more the level of calprotectin, the severe is the damage to the intestine. So next, coming on to the serum amyloid A, again it is an acute phase plasma protein elevated in response to the inflammatory cytokines basically. So it is either measured in blood or urine to detect inflammation, and it can be measured non-invasively in urine. So I am stressing these things because majority of the biomarkers whatever I have spoken so far, they are measured non-invasively. That is, either they can be measured in the urine or in the feces. So no need to collect extra blood or no special things are required for them. And of course we have our interleukin 6 and interleukin 8, both of them are measured in the blood and they are inflammatory cytokines, and both of these are, because they are related to the inflammation, they are important things which help us to distinguish NEC from spontaneous intestinal perforation, that is, which is not related to any kind of inflammation. And so next, this is again, as I discussed, transforming growth factor beta. So this is a growth factor deficient in the intestine of premature infants. So measured in the blood to indicate deficits in the intestinal development. So this can indicate infants at greater risk of NEC from the time of birth. That is, the lesser the concentration of TGF-beta, the more the chances of developing NEC. So again, it has some kind of therapeutic benefits. So I would like to summarize these things. So intestinal fatty acid binding protein is very highly specific, so it's a diagnostic marker and also can be used as a severity marker. So calprotectin is a severity marker, the serum amyloid A, interleukin 6 and 8, they are severity markers and they are able to differentiate NEC from non-inflammatory pathologies like spontaneous intestinal perforation or feeding intolerance, etc. So TGF beta, so able to predict premature infants at risk of NEC. So what is new in imaging in NEC? So near infrared, apart from the ultrasound, X-ray and MRI and CT, so this is one of the newer armamentarium. So near infrared spectroscopy, which involves placement of probes over the skin. So what does it do? It measures the splanchnic tissue oxygenation levels, but the important drawback is it has a shorter depth penetration. So because of this, it may not reflect the total intestinal, the entire intestinal oxygenation may not be reflected with this. That is one of the important drawbacks of this. However, it is one of the promising tools which has been developing now. So coming to the preventive strategies. So as we all know, in the West, just like the management of congenital diaphragmatic hernia or tracheoesophageal fistula, so there has been stress upon even treatment of NEC at tertiary care centers. Just like how all the complex anomalies are being sent to one of the tertiary centers for management, nowadays even all extremely low birth weight infants and very low birth weight infants are being referred to tertiary care centers for the comprehensive management, that is both medical and surgical management of NEC like thing. So very much stress is laid upon the infection control measures in the nursery, and of course augmentation of the host defense in the form of either oral immunoglobulin preparations which are now being available, the maternal glucocorticoid administration. So previously glucocorticoids used to be administered for lung development, now the same thing is being applied also for the intestinal development. And of course we have our breast milk which is being given as trophic feeds. So this we know the probiotics have already been, there are so many studies on this, but what is now new is the prebiotics and the postbiotics. So what is prebiotics? They are non-digestible dietary supplements such as long chain carbohydrates or mucins. They in turn promote proliferation of the beneficial commensal bacteria. Probiotics are live bacteria. So in few studies they have demonstrated that it can cause secondary damage, but prebiotics, they are not live organisms, they are just long chain carbohydrates, they help in beneficial of the normal bacteria. And postbiotics, that is butyric acid derivatives, again they are similar to prebiotics, so which help in increasing the capacity of the normal intestinal bacteria. So what are the newer treatment things? So as we discussed the importance of toll-like receptors, again toll-like receptor 4 inhibitors have been developed so far and still in the research level, but yet to come into the clinical practice. This is one of the most important things which is awaited. And of course, as we saw, platelet activating factor again, so again antagonists are being developed against that. And heparin binding EGF like growth factor, the amniotic fluid, because the premature infants they have been lesser exposed to amniotic fluid in the intestine. So amniotic fluid infusion into the gut of the premature infants is also being tried as one of the important treatment modalities. And of course stem cells, the amniotic fluid stem cells, mesenchymal stem cells and enteric stem cells, they are also in the treatment protocols. So of course being surgeons, what is new for us with the surgical things? Sorry, I am not having much about this. So we have still in the same area, but only thing this study which was published in 2006, it categorically tells that there is no increased benefit of doing an exploratory laparotomy versus just placing a severity, the peritoneal drainage. So peritoneal drainage or laparotomy doesn't affect 90-day mortality, it doesn't affect the rate of dependence on TPN at 90 days post-intervention, did not affect the total length of hospital stay. So based upon this paper, NICD supported randomized controlled trials was started in 2010 and the results of which is still awaited. Probably the next year we will be getting those results. So this may categorically change how the treatment for NECs so far can be changed totally drastically. So coming on to the future friends, so as we saw, this is more for the neonatologist. So whenever a preterm child is admitted in the NICU, so what may be the future? For all preterm infants, we get a TGF beta levels. So TGF beta low, that means they have increased chance of developing NEC. So symptoms and signs, these children develop symptoms and signs related to NEC, do the biomarkers. If the biomarkers are positive, treat as per NEC. So if the TGF beta is high, then they have lesser chance of NEC, so may consider fast feed advancement, because again the neonatologist being slow speed advancement for these children. So this is one of the treatment protocols which can be evaluated so that they may consider faster speed advancement even for these children. So when this exercise come to any of these, this one we have a doubt whether it is either interstitial perforation or whether it is necrotizing enterocolitis related perforation. So again the biomarkers are there for us, interleukin 6 and 8. So if these are raised, again this suggests some kind of inflammation. So more towards an NEC kind of thing. If they are low, then increased chance of spontaneous interstitial perforation. Thank you so much.
Can you just tell us about maternal steroid, you said?
Yeah.
So what is the role and which are the mothers who will get it? Like, what is your idea?
Especially mothers who are having some pre-eclampsia related hypertension things, and when they are expected to deliver early. So when the obstetricians feel that the delivery cannot be postponed further, when it needs to be some sort of the cesarean section has to be done. So just like we give the glucocorticoids for lung development for premature infants, so now the research is telling the same thing which can be applied for the intestinal development also for these kind of children. So it is supposed to increase the levels of TGF beta levels within the gut intestinal levels, which in turn has a protective effect on the overall development of the baby.
Also the investigations which you told us, all the recent advances which are easily available in India, what are we practicing here? What is your experience?
Right now I must say it's still not yet available in India. The intestinal fatty acid binding protein and calprotectin levels are being, we are seeing that in Indian Institute of Science. So they are having some studies going on there also. But effectively as of now it has not come into the clinical setup as such. But probably within the next 2 or 3 years I think we should be hopeful of this. The premature infants, they are not, normally when these infants are there in the mother's womb, they will be swallowing the amniotic fluid which has a lot of growth factors and things which are responsible for the intestinal development. So now they are come out of the mother's womb, so they are not exposed to the amniotic fluid. So the commercially available amniotic fluid is there, so again this can be infused into the gastrointestinal tract, which again has a promoting effect on the gut. It's been commercially prepared.
Just one more question here from this side.
Yeah.
No, you initially gave us a classification of the types of NEC. So there's one related to blood transfusion also, isn't it?
Yeah.
So just tell us what are the guidelines, when should we or should we not give blood, because we do have a tendency to give blood to these infants because the hemoglobin is dropping. But I think even 20 years back there were concerns about this.
Yeah.
So throw some more light on that.
Exactly. So now the newer things regarding the packed cell related transfusion for premature infants, especially they have seen a lot of studies are there when these premature infants having a hemoglobin of say less than 6 grams per deciliter, and when these are clinically symptomatic, either they must be having hypotension or tachycardia. So when these, when they did a lot of studies regarding that, and they saw when these premature infants are transfused with either at least even if they saw even 1 unit of 1 aliquot of packed cell transfusion, also they have seen the development of NEC-like picture in such children. So they are not sure how to avoid that, but as far as possible, we will try to minimize any kind of transfusion in this premature infant unless it is absolutely required. Yeah, that is different, sir. That is totally different, sir. This is the premature infants having anemia due to various causes and being the packed cell transfusion given for that specific purpose.